Thank you, guys. It's a pleasure to be here and to have opportunity to give this presentation. I apologize. This is also my first in-person talk after 1 year, so we'll work through this together. The talk is about lung transplantation during the COVID time. We will touch on the first how the pandemic affected the lung transplantation in U.S. and across the world. We'll talk about indication for the lung transplantation and how the COVID-19 ARDS fits to that criteria. And we'll talk about our experience with COVID-19 ARDS and some of the things that we see in this, the particular things that we see in this group of the patients. So I will start with this first slide, which is where we are currently with across the world with pandemic. This is from January 18. It seems that for reasons that are not clear to me, that actually pandemics is subsiding across the world over the last couple of weeks. And this is how it fits to in United States, also data from about 2 weeks ago. So now the world of the lung transplantation and how that fits to how that changed over the time during the COVID crisis. So we did in 2017 across the world around 4,500 lung transplantation. And it's important to keep in mind that just in the United States, every year 150,000 people die from COPD. So lung allocation are very important, and it's very scarce resource. So when we are thinking about who is going to get the lungs, it's very difficult decision. But also in the context of the younger people who are dying from the COVID-19, but regard also of other lung diseases. So pandemic changed a lot the environment for the transplantation across the world. Number of the lung transplant, particularly in the first 3 months of pandemic when we were facing a lot of unknown, decreased for about 25 to 80%, different from country to country. In the first 3 months in France, deceased donor transplantation went down from 90%, so the almost was non-existent in the first 3 months of the pandemic. In U.S., that was a little bit less, 50% down. Similarly to that, lung transplantation was decreased by 40%, and this didn't go without any consequences. So as a result of the less transplant, more people were dying waiting for the transplant. So according to some data, there were increased from 10 to 40% in waitlist mortality because of decrease in the number of the transplants. Obviously, availability of deceased donor was transiently decreased during these 3 months. And this study from Spain that was showing very nicely. Spain, by the way, has the best allocation system for the transplanted organs in Europe. And as you can see, between the March and the May, number of deceased donors, and let me see if this will, actually it's harder. Number of deceased donors decreased significantly over the last 3 months and then went almost to the baseline, how it was before the pandemic. In United States, when we are looking at the data regarding the lung transplant, on the beginning of a pandemic, there were a huge peak in the wait list in activation. Concern was, besides many other concerns, with the additional immunosuppressed patients who have significant lung disease, they have higher chances to get the COVID, and therefore many patients were inactivated waiting for the lung transplant. New waiting list additions were significantly decreased during the pandemic, and they still didn't come back to the level before the pandemic. As well, availability of the deceased donors, organs, lungs, went down and went almost close to the baseline before the pandemic. Lung transplantation volume, however, are significantly decreased in the United States still, and although We'll talk about that a little bit more in the following slides. There are discrepancy from the region to region, how some regions were affected regarding the COVID-19. They respond differently regarding the number of the lung transplants, and we'll show that later. So what are the risks during the COVID time regarding the lung transplantation and any other solid organ transplantation? One of the obvious risks is a possible transmission to the staff. There was actually recent case reports when the donor was tested with PCR, and PCR was negative. They went to retrieve the lungs, and actually the surgeon got infected with COVID because the patient was actually positive with the COVID. There is a lot of problems with the ICU and the transplant coordination. I'm sure here as everywhere else there were a lack of the ICU beds at the time of the peak of the COVID, and that's a certainly problem when you are thinking about bringing a patient for the lung transplant if you don't have the ICU beds for the care after the lung transplant. Again, we mentioned about that risk of exposing the recipients to additional immunosuppression and maybe make them more prone to develop infection, COVID-19. We don't know what is the impact of this virus on rejection. We still don't know that. We know that some viruses, such as CMV, will cause more rejection if the recipient will develop that viral infection. So it's uncertain how this will impact, how the COVID-19 infection can impact potential recipients. As we mentioned, paucity of supplies, personnel, and intensive care beds is the significant problem. It depends about where the certain region is regarding the incidence of the coronavirus infection. And also, when we are consenting a patient for the lung transplant, we have very extensive discussion about risks and benefits. And in this uncertain time, we were not able to predict or suggest or discuss how high is the risk of the lung transplant patients to develop COVID after, and what are the chances of survival if they will develop COVID. And we'll talk a little bit about that in the following slides, what we know now. However, lung transplant is a life-saving procedure, and decision about continuing the transplant or not doing the transplant should be based on the patient's well-being. Also, when we are thinking about decisions, it's important to be aware about the prevalence of infection within your community and what you are expecting about load in intensive care and how much personnel you will have available for this patient. And that's a part of this capability of each center to manage the workload. It's important to maintain infection control procedures. And what is the kind of part of the culture in the lung transplant ward is always to respect the patient and donor autonomy about these circumstances regarding the lung transplant in the settings of the pandemic. How we approach now to the donors change really over the time. We are now testing all the donors and recipients for the infection. Regarding the approach to the donors for the lung transplant, we test them with one test is usually PCR, one test is bronchoalveolar lavage. In this particular case that I mentioned in this organ procurement organization, they did just PCR from the nose for that donor who turned out to be positive. We do the CT of the chest for all donors, which we are not doing routinely prior to the pandemic. And when we have the patients who are highly sensitized, which means that they have a lot of HLA antibodies, and therefore their waiting time for the lung transplant will be prolonged, we'll consider desensitization procedures. But in these circumstances, in the presence of the pandemic, we try to avoid additionally to immunosuppress the patient in order to wait for the lung transplant because of the risk of infection. However, having said that, we try to prioritize highly sensitized patients and transplant them sooner if the right match will come. Immunosuppression also changed to some degree during the time of the pandemic, and there is a lot of variability from center to center. Practice is generally extrapolated from the previous experience with different viruses. And for majority of the lung transplant programs, and again, I will show you the data how this was present across the nation. For the mild infection, there were no changes in immunosuppression. However, if it changes immunosuppression, we usually will decrease the dose of antiproliferative drugs such as Imuran and the mycophenolate, and will keep the calcineurin inhibitor at the same level. There were studies showing that instead of tacrolimus, which is our standard in the lung transplant, that converting to cyclosporine with lower goals was one of the options and had a better result. Also, it's not clear completely how the pharmacokinetics of our drugs is going in the context of the different antiviral therapy that patients are getting for the COVID-19. And also what we noticed that, and there is a data about that now, that patients who were on CNIs, calcineurin inhibitors, they have prolonged viral replication. So we see the patients who are for very long time positive. But also there is a data about decreased inflammation in the patients who were on the strong immunosuppressive therapy after lung transplant with less interleukin-6 and less other of the markers of inflammation. So we also, in our program, we had one patient who died from COVID-19, but we had at least 10 patients who were severely immunosuppressed with high doses of tacrolimus, who were completely asymptomatic, having the actual infection. So actually their family members have more symptomatic infection than the patient who was actually a lung transplant recipient. So it's kind of unclear really how the patients with immunosuppression bear in the context of the COVID. So as I mentioned, majority of the centers, and I'll kind of little bit, I was trying to change the slides before this, and so but my flash drive didn't work, so I'll start with this slide. This is across the United States, how the lung transplantation change in different regions. And this is predominantly this is exactly period of time from March 1st to end of the May. And as you can see in the dark blue, which is northeast of United States, the numbers went most significantly down, whereas in the northwest, somewhat down, Midwest was in the between, and in the south, actually, the number of the lung transplants increased during the period of that time, probably partially because of the less prevalent infection in the south during the springtime. This graph is the data from the Duke, which they actually have highest number of the lung transplant from the March to June over the last 5 years. So there were discrepancy from region to region. Similarly, in our program, we have a highest number of the lung transplant in spite of the very high prevalent pandemic in this area. So, as the interim summary, lung transplantation during the pandemic time, there were no difference in the type of the donors that we are seeing. Some solid organ transplants are now utilizing COVID-positive donors, lungs we are not still utilizing COVID-positive donor from obvious reason, because COVID will be in the lungs and you don't want to transplant that lung. Negative donor and recipient tests at the time of the transplant are minimal requirement for the proceeding for the transplant. And as I mentioned, we are doing routinely lavage on all the lung donors, but especially we'll check this lavage for the presence of the virus in the context of the potential transplant. We try to keep all transplanted patients in a single ICU because of the risk if they are mixing with other populations. And the multi-institutional collaboration is crucial. What this means, when we have during the peak time of the COVID, we will ask, for example, the hospital in Texas to procure for us lungs and send us lungs here, and we'll pick it up so that we decrease the risk of exposure to our staff and the members of the team. And nowadays, when we are talking about lung transplant and when we are talking about consent for the lung transplant, we always talk about COVID-19 and we explain the patient what we know, what we don't know. So just reviewing the preliminary data from the registries that we have in the Seattle at University of Washington regarding how the lung transplant recipients bear during the COVID crisis. So mortality for the lung transplant was higher than the mortality for the other solid organ transplant. Didn't reach statistical significance because these numbers are not overall super high. Mortality for all solid organ transplant decreased, statistically significant, from the springtime to the summer and the fall. And when we are comparing the lung transplant with outcomes from other solid organ transplants, there were no statistical significant difference in the ICU admission and mechanical ventilation, although there was a trend towards more ICU admission for the lung transplant recipients. When we look at the therapy based on this registry data, and what is important to emphasize, this is not controlled data this is pretty much uncontrolled data. This is just patients who were on therapy and patients who were not on therapy. We don't look at we don't have data yet for the severity of disease or anything like that. So patients who were on remdesivir, there were no difference in 28 days of mortality for patients who were not on remdesivir. Steroids very similar, actually slightly higher mortality, but somebody could argue that these patients were sicker if they were treated. However, reduction in immunosuppression also didn't kind of bring any difference in mortality, and the numbers are becoming more and more robust. Here we have around 350 patients in this group. 24% of the patients treated for the COVID who were lung transplant recipients have superimposed bacterial infection, with 11% of them with evidence of infection. So these are some of the features that we see for the lung transplant patients who got COVID-19. And this is also very interesting comparing the spring, summer, and fall. As you can see, mortality was strikingly higher during the springtime versus during the summer and the fall. Based on the previous slide, I don't think that we can attribute that to our therapies for the COVID. It's kind of probably there is a multiple possible explanation why that is the case. But that's what our registry data are showing. Excuse me. So switching now to the lung transplantation for COVID-19. And this is on the right part of the slide, you can see the actually COVID-19 lungs. And on the left, you will see the new normal implanted lungs. So when we are talking about in the ARDS, COVID-19 induced ARDS as indication for the lung transplant, we should put it in the context with all other indication for the lung transplant. As I mentioned before, there is 150,000 people who die every year from COPD in the United States, just. And we do in the United States around 2,900 lung transplants. So there is a huge need for the organs. And we're all facing this dramatic situation when these young people are dying from the COVID. But in the back of the mind of the lung transplant physician, we also think about our chronic patients. So primary indication for the lung transplant here in the blue, becoming more and more prevalent are interstitial lung disease. In the green is the COPD, and relative to the ILD, COPD numbers are staying stagnant or going down. When you look at whole list of the indication for the lung transplant over the last 23 years, finishing with June 2018, you can see that there is no ARDS. And the simple reason for that is because transplant for ARDS is extremely rare. And again, there is a reason for that, because the sicker the patients going to the lung transplant, the outcomes are worse. So if somebody goes from the ventilator to the lung transplant, the outcomes will be significantly worse than somebody who actually came in the hospital for lung transplant. So this is the study which was one of the 2 or 3 available studies looking at the outcomes of the patients with ARDS if they got a lung transplant. They had just 9 patients, and in this particular study, survival was really good, 78%. Expected 1-year lung transplant survival is somewhere around between 85 and 90%. So not much worse than the standard expected survival at 1-year point. However, when this was the actually abstract which was presented last year, just 6 patients were part of this study, ARDS as indication for the lung transplant. The 1-year survival was somewhere around 50%, which is much, much worse than our expected survival for the regular indication for the lung transplant. And that put kind of in the context what is the benefit that we give to society when we are transplanting the patients for the COVID-19 ARDS. And we'll talk about that a little bit later. I will review the now available data that we have for regarding how the patients who were transplanted for COVID-19 ARDS, how they did. This was experience from China, and as you can see, typical chest X-ray and typical CT images for the patients with COVID. This was a report of their first 3 lung transplants for the COVID-19 ARDS. The oldest patient was 73-year-old, which is considered quite old for the lung transplant. In our program, we'll accept the patients up to age of 75, but for COVID-19, we will not accept the patients older than 65, particularly because patients who is 73 and otherwise have just lung problem and is living at home, it probably will have better outcome than somebody who is 65, who is on the ventilator, on ECMO, and heavily sedated. All their cases, all the patients were negative for COVID-19 at the time of the diagnosis, at the time of the transplant, and all the cases were done on the VA ECMO. All 3 patients were supported postoperatively on the VV ECMO, and they used the lower dose of CNI postoperatively with concern about reactivation of the virus after the lung transplant. 2 of 3 patients actually survived. And interestingly, the oldest, around 73-year-old, he did survive. It's always, when you're thinking about COVID-19 ARDS indication for the lung transplant, we always think about when is the right time to consider lung transplant. because if the patient has a chances to recover some of their lung function, probably we shouldn't rush with the lung transplant. To talk about some guidelines and some suggested criteria for that. But before we consider the patient for the lung transplant, we should establish that patient's respiratory failure is likely reversible and patient is not going to get better. In this particular Chinese experience, that's what they did. They also wanted to have PCR negative potential recipients prior to proceeding with the lung transplant. In our protocol, we have the patient's recipients at least 2 negative PCRs prior to consideration of the lung transplant. And in the protocol in China, all of these patients have to have the single organ failure, which is very important because if the patient has additional organ damage or organ failure, that further increases the risk of the transplant and probably contributes to mortality. So that's pretty much what is universally accepted as the minimal criteria for the lung transplant, that this patient shouldn't be on dialysis, shouldn't be on the CRRT, shouldn't have significant kidney damage prior to proceeding with the lung transplant. Austrian experience, the next lung transplant which happened was in Vienna, and their experience was a little bit different. Their approach was a little bit different. This is again complete whiteout of both lungs prior to the lung transplant and the chest X-ray after the lung transplant. But they actually proceeded with a transplant with patient who was PCR still positive, but the viral cultures were negative. Patient was heavily sedated and unable to do the consent, so family did consent for the patient. This also has a huge implication for the future when the patient, ethical implication for when the patient wakes up and, when they realize that they are living with new lungs, that they're committed to live the life with immunosuppression, potential lot of complications, and but we'll touch on that a little bit later. They did a desensitization prior to the lung transplant because their patient was highly sensitized and they couldn't get the right lung match for the patient. And the surgery was very complicated. They had the patient got 30 units of PRBC and 5 units of platelet during the surgery. They also used intraoperative ECMO and postoperative VV ECMO. And their patient developed antibody-mediated rejection after the surgery. So they have to further intensify the immunosuppression and treat aggressively patients with immunosuppression after strong immunosuppression after the surgery. Patient was in ICU for 63 days. Just for comparison, usual hospital stay for the patients who get the double lung transplant is between 3 to 4 weeks. So this patient was 63 days in ICU. And COVID-19 PCR turned out to be negative after 10 days after the lung transplant, and they didn't have any problems regarding reactivation of the virus and so on. The multiple lung transplant that happened across the world led to this article from the group from Toronto. Toronto is the biggest lung transplant center in the world. They did before the pandemic, they did 208 lung transplants in their hospital. And their recommendation is to have the patients who will be candidates for the lung transplant with COVID-19 to be younger than 65, to have single organ failure, and at least 4 to 6 weeks after initial respiratory failure. And this is because of to give enough time for the patient to recover, if they will recover from the respiratory failure. They suggest that all patients should be negative for the COVID prior to the lung transplant, and that lung transplant should be done in the centers with high risk, who have experience with high-risk transplants, because I will show you our data in the following slides. It's much more complicated surgery than the regular lung transplant surgery. Also, they recommend that surgery should be done in the centers with low waitlist mortality, which means that in the centers who will have a higher number of the lung transplant and smaller waiting time for the lung transplant. Because simply these patients, if they're waiting longer, they will have more complications and likely die. And they recommend that patients should be awake and able to discuss lung transplant, to know what they're going in and what they can expect after the lung transplant. Because, as I said, from our experience, we see that some situations. I'll just comment about one of our patients who was compliance is the big issue for the lung transplant patient. They have to be very compliant to very complex medical regimen. So we transplanted one physician, ER physician, who is from Texas, and they committed they will stay 1 year in Chicago, and we'll be following them very frequently and so on. And even him, being a physician, when he got better, he left for Texas. So we are struggling how to find a way how to follow up with him, and they have to have frequently blood testing, and particularly if they're leukopenic, it's sometimes on weekly basis. So it becomes really kind of organizational nightmare when the patient leaves and if the patient is not compliant. So this brings us to the experience of our first lung transplant. And this particular patient was in any possible media outlet in the country and across the world, so there will be some pictures of her later, which are HIPAA approved. So she got intubated at the end of April. After 1 week, she got an ECMO, developed severe ARDS and progressive lung injury. She had a necrotic cavity in her left lower lobe due to Serratia infection with ongoing pressure requirement. A few days prior to the lung transplant, actually, she got a right pneumothorax, and they went to put a chest tube, and they put a chest tube through the liver, which caused liver laceration. So she started to bleed profusely, was on 4 pressors, barely survived. So actually, her mother was from North Carolina, so they were calling mother over the phone to come because we wanted to withdraw the care. And the next day, the lungs came, and she got transplanted. And she was on ECMO after the lung transplant for 7 days and on the ventilator for 12 days. This is her progression of the chest X-ray prior to the lung transplant. On the last one, chest X-ray in your left lower corner, you can see the large cavitary lesion with pocket of the air. And she was treated unusual way. That was in the springtime. I think she was transplanted sometime in June with high PEEP, which was adjusted based on esophageal balloon and a proning. She was on ECMO. We used all the medication that were suggested at that time. And she didn't get better. So the only chance was lung transplant to actually help her to live. And this is her lungs that were explanted during the case in the lower part, and new lungs after the lung transplant. And this is how she was running after 5 months after the lung transplant, and that's the last picture down there. So she did really well, but youth always helps. She was 28 years old when she went for the lung transplant, and she went through all of this. So this is our experience comparing the transplants. What is the difference between COVID-19 lung transplant and lung transplant in general? As you can see, what is statistically significant here is the length of the operation. So surgery is much more complicated for the COVID-19 ARDS than for the other patients. And this is primarily because of a lot of bleeding, a lot of adhesions, a lot of infection in the chest cavity and so on. They need much more of the blood products during the surgery. And as you can see, all the statistically not significant because overall small number of the patients. There was a strong trend for the longer ventilation after the lung transplant for the COVID-19 ARDS lung transplant group. So these are the countries where the COVID lung transplant happened. It happened in China, Austria, United States, South Korea, India, and Mexico. And it's becoming more prevalent also in the United States. However, it is still indicated just for the very selected number of the patients who will fit criteria. And our criteria are, as I mentioned, 2 PCR negative, single organ failure, body mass index lower than 35, and for the patient to be able to be to some degree awake and to be able to participate in some kind of physical therapy. We have patients who were able to be walking on ECMO with COVID-19, but will not ask all of them to be like that, but they should be able to participate with some degree of the physical therapy. So we did so far 10 transplants, all of them are live. One was on the VV ECMO postoperatively, and we are probably the largest number in US and across the world currently for the COVID-19 lung transplant. Before we proceeded with lung transplantation, there were some concerns, and some of them did materialize, some of them fortunately didn't. We were concerned because most of our patients got convalescent plasma, that they will have more antibodies and therefore more antibody-mediated rejection after the lung transplant, but we didn't see any of that. None of our patients have any issues with that. On the other side, most patients had the problems with the kidney after the lung transplant and some degree of the acute kidney injury. We have one patient who actually was not on dialysis prior to the lung transplant, but ended up on dialysis after the lung transplant. And we are learning more that it seems that actually virus affects the kidneys adversely, and part of the patients who are who have acute kidney injury during the course with COVID-19 partially is because of the hemodynamic instability and ATM, but it seems that there is some direct damage of the virus on the kidney. And all of these patients had longer hospitalization and prolonged recovery. As I mentioned, one of the biggest concerns going for the lung transplant for this patient is frailty and how they will do after the lung transplant. And there is a whole body of the literature about frailty prior to the lung transplant. I have to say that we disregarded for this particular group of the patient most of that because they are usually younger and stronger. And it seems so far the results were good, but we are very concerned about how this will kind of impact the patient in the future and outcomes for the long term, because obviously they are much more frail than our standard lung transplant patient who is going for the lung transplant. And the long-term complications are known. I think our first lung transplant is somewhere for COVID-19 is somewhere now 7 to 8 months after the case. So we really don't know how the long-term outcomes will be. As I mentioned, all COVID lung transplant patients had increased risk for the significant increase in the 1-year mortality. Here on this slide from International Society for the Heart and the Lung Transplant, you can see that patients who were on the ventilator having significantly increased 1-year mortality, as well as the patients who were hospitalized prior to the lung transplant. Both of these fit to the patient with COVID-19 who got a lung transplant. And on top of that, the patients on ECMO, majority of them. In this, what was the most significant predictor of 1-year mortality after the lung transplant was actually end-stage renal disease. And we will not transplant anybody who has definite additional kidney damage or kidney failure. And again, to put in perspective impact of society of the lung transplant and how this patient, how the transplanted from COVID-19 patients relates to the other standard indication for the lung transplant, you can see that when you look at the lung transplant patients, barely 13 or 14% of them will go back to work within the first year after the lung transplant. How that will be for the COVID-19 patients who are much more frail than this patient, it's kind of hard to say. How that will be, on the other side, they are usually younger than the standard lung transplant patient. So maybe how that will work out, we don't know. But this is kind of, I put this slide to put in perspective what lung transplant does to the patients who go through that. To be completely fair, most of the patients who have lung transplants are in their, not most, but average age is high 50s. So they are close to their retirement age. So that's another possible reason why these numbers are looking this bad. But lung transplant has the worst outcomes than any other solid organ transplant for many different reasons. And when we are thinking about COVID-19, ARDS being a very rare indication for the lung transplant and with worst outcomes in comparison to this standard outcomes from the lung transplant, these are all ethical questions that we ask ourselves. And I will finish with last slide with some of these ethical questions which we are asking ourselves in everyday practice. We are getting every day few referrals from across the country for the lung transplant, and you try to do the best possible thing for the patient, and knowing that you have the other patients who are also waiting for the lung transplant. So it is, keep in mind that it's really scarce resource, and you see the patients dying in the hospital, but at the same time, there is 150,000 patients who die from COPD every year, not necessarily in your ICU, on ECMO, and on the ventilator. ARDS as an indication for the lung transplant has a worse survival. We are aware of that. How this is impacted with younger age for this particular COVID-19 ARDS patients, we don't know. These patients who go for the lung transplant with COVID-19, they have usually less comorbidities because they are younger than the older patients. However, particularly for these rare occasions when we transplant patients and they don't know that they are going to have a lung transplant, and the family actually consent, psychological impact when they wake up from all of this is huge. It's kind of, somebody decide on their behalf that they will live whole their life, the rest of their life, on a very complex medical regimen with lots of potential complications and so on. That's why we try to have the patients awake and be able to understand what lung transplant means. Because obviously family being desperate that their dear one are dying, they will agree on everything. And we don't know what are the long-term outcomes of the transplant for the COVID-19 ARDS. So I'm not leaving you with very optimistic picture and the question, but try to give you a realistic picture where we are with this, because we want to help the patients, and the younger the patients are, I think the outcomes will be better, and I think it makes more sense to do the lung transplant and taking a risk for these patients on their behalf and on our behalf. But it is not clear-cut, and that's why the lung transplantation for COVID-19 ARDS is just for the very small, very particular group of the patients who fit criteria. I will stop there and open to the questions. So generally, we try to have the donor be not much older than the recipient, but the general age is less than 65.
Do you think like the COVID crisis like affected the donors' age?
Not really. I think our donors, the same donors that they were before, motor vehicle accidents, gunshots, wound, and so on. Not really much different. It's a cranial bleed, and so on. Yes.
I was very impressed about the numbers of patients that they are doing in France versus the United States. In surgery, as you know, in France, they have a tendency to do in the single centers as opposed to the United States that every hospital that they think that they can do it, they will do it. But your statistics, 10 out of 10, are very, very impressive. How old is your longest survivor?
For the COVID-19 ARDS transplant, 65.
65 days?
65 years.
Because you said that the patients are still in intensive care.
For ours, none of ours is, one actually came back, but not anymore in intensive care. But that particular patient who is 65, he's in LTAC.
Yeah, the curves of people that they are eventually going to normal life are dismal.
Yeah.
Therefore, it would seem to me that this is really close to an experimental type of procedure. And I suppose cannot be, with this type of mortality, consider anything less than that, and sort of have a word of caution to any hospital that is not fully capable of doing these procedures. By the way, any of your patients had bilateral lungs and heart, or they are only lung transplant?
Only lung. The only one in the United States that was done both, it was in the Vanderbilt.
Thank you.
Yeah, and I completely agree with you. The lung transplant outcomes are not great, and especially for this group of the population. 1 year expected survival, if we talk about that, 5 year expected survival is around 56%. So it's almost 50-50 at 5 year point for all lung transplant recipients.
I have one question. For the people that are ventilated or on ECMO for quite a while that aren't at Northwestern, at what point do you guys appreciate a phone call or a referral? Are we waiting for people that are on ECMO for a week, 2 weeks, a month, 3 months?
So it's quite variable. We have actually one patient, probably around that 6 weeks kind of timeline. If the patient is not getting better, it's probably a good idea to kind of call us. We have one patient who was transplanted after 5 months of ECMO, and he's doing really well. But he was not vented, and he was the one who was walking on ECMO. But generally after 6 weeks, after the respiratory failure is ongoing for 6 weeks and there is no improvement, I think it's a good idea to contact us.
I have one quick question. So when you were talking about your inclusion criteria for people trying to get a lung transplant with COVID, I noticed that you mentioned that you had to have single organ failure. While we've been here, we've been noticing that a lot of these patients tend to have a lot of kidney injuries. And I wanted to ask you, is that the reason for the 4 to 6 week wait period in between to just see if the kidney numbers would normalize before getting considered for a lung transplant?
That's also, but also for the lung failure to see if the lungs are, if it's irreversible lung failure or not. If the lungs don't show any signs of improvement over the 6 weeks, then probably it's time to think that they will not improve. And also, we would like to see that kidneys are getting normalized before we are considering the lung transplant for the also kidneys and the lungs doing, not just for this indication, but for the other indication. But they have to be really young. They have to be probably younger than 40 if they will be considered for the lung and the kidney.
I just had a quick question too. Have you guys noticed in any of your patients that there's reactivation or reinfection of the virus?
No, not on the single one.
Okay, with that, I will thank Dr. Tomic for joining us for Grand Rounds. I want to be respectful of all your guys' time, Dr. Tomic's time, and our Zoom participants. So thank you so much for joining.
It was a pleasure, guys. Thank you so much for inviting me.